In the next two sections, we're going to begin to apply what we've learned. You can't talk about pulmonary physiology without talking about pulmonary pathophysiology. In the first section of Applied Pulmonary Physiology, we're going to discuss asthma and chronic obstructive pulmonary disease, two of the most common diseases you'll see as a physician. In the next two sections, we're going to talk about applied pulmonary physiology. This will reinforce some of the concepts that we introduced earlier in the lecture series and apply them to patient diseases that you'll see out on the wards and in the clinics. Every pulmonary disease manifests itself by some abnormal pulmonary physiology. The great thing about studying pulmonary pathophysiology is the stuff that we've spent time on over the past few lectures is stuff that you'll use taking care of patients with pulmonary diseases. Asthma is a very common pulmonary disease. Many of you may have. Its prevalence is listed at about 5 to 10%, but I suspect that's going to be increasing. The prevalence is higher in children. The hallmarks of asthma are airway hyperresponsiveness. The airway responds to some stimuli. Typically, the response is bronchoconstriction, reversible airway obstruction. The airways get smaller, the radius decreases, airway resistance increases. Also involved in that response is mucosal inflammation, and anti-inflammatories are an important treatment of asthma. The problem is in the airways, not in the alveoli. So typically patients with asthma have normal gas exchange. Remember, asthma and all obstructive diseases are expiratory diseases. The problem is in getting air out of the lungs. We can see this in that the abnormal breath sound of asthma, the wheeze, is heard during exhalation. Students will sometimes ask that if asthma is an expiratory disease, how come the patient feels short of breath all the time? And it's a good question. The abnormal physiology is manifested during exhalation. There's resistance to airflow. So we hear abnormal breath sounds during exhalation, and those breath sounds are prolonged. People have a long expiratory phase, and you hear wheezes during exhalation. But the work of breathing is increased throughout the respiratory cycle. Therefore, the patient feels short of breath all the time. They don't notice just a problem during exhalation. Let's do a question. All of the following PFTs could occur in an asthmatic patient, except the correct answer here is A. Patients with asthma can have normal PFTs in between episodes of flare. Therefore, they could have a normal FVC. B, they could obviously have a reduced FEV1 to FVC if they were in a flare, or they could have a normal FEV1 to FVC as in the case of D. A is the correct answer, and we would not expect a patient with asthma to have an increased FEV1. Let's take an example where an asthmatic patient was having an attack. You give them oxygen, inhaled albuterol, remember it's a beta agonist, and IV steroids. Which of those treatments will have an immediate effect on the FEV1 to FVC ratio? The only one that will act immediately to improve the FEV1 to FVC ratio is the albuterol. Answer B. Your caring bedside manner won't hurt either. If we were to draw a blood gas on this patient with an asthma attack, which would we expect to see? Let's go through each of these answers. Very often, patients with an asthma attack will hyperventilate. Because of the increased work of breathing, because they're nervous about being in the hospital, they'll initially hyperventilate. Therefore, the person can have an elevated pH or a low PaCO2. The correct answer is not A or D. Additionally, we would expect it's possible the patient to have normal gas exchange. So C and E are rolled out. The correct answer in this case is B. We would not expect a patient with an asthma flare to be hypoxemic, especially hypoxemic to the degree that we demonstrate in answer B with a PaO2 of 50. COPD is another example of an obstructive lung disease. COPD represents chronic obstructive pulmonary disease, and it's a combination of either emphysema or chronic bronchitis. Only 15% of smokers get emphysema, and it's some question as far as why only 15% are unlucky. Let's think about the Venn diagram of COPD. Emphysema is defined by abnormal pathology. When we do a lung biopsy, we see the loss of alveoli and the loss of elastic connective tissue. If we were to pick a pulmonary function test that would best describe this, we would expect to see a low diffusion capacity. Chronic bronchitis, however, is defined by history. A patient must have a chronic productive cough for at least 3 months in 2 consecutive years. Some patients have just emphysema, some patients have just chronic bronchitis, others have both. All of these patients we would expect to have a low FEV1 to FVC ratio. There are many smokers that don't meet the diagnostic criteria for COPD that do have the low FEV1 to FVC ratio. The airway obstruction in these patients is less reversible than the airway obstruction that we typically see in asthma, although there can be variation in the FEV1 to FVC ratio. Sometimes the emphysematous patients are referred to as pink puffers, and the chronic bronchitis patients are referred to as blue bloaters, although the line between these two certainly can be grayed. GH is a 70-year-old longtime smoker with emphysema. His FEV1 and FVC are the same as our asthmatic patient. What pulmonary function test would we expect to be lower in GH? If GH has emphysema, we know that he's lost alveoli. He's lost some of the elastic connective tissue. So we would expect his diffusion capacity to be lower, his DLCO, and D is the correct answer. His FRC we would expect to be higher because of the loss of elastic recoil pressure of the lung. A 65-year-old woman comes to the emergency department with a COPD flare. She's hypoxic and you draw blood gas. She has a pH of 7.25, a PCO2 of 75, and a PO2 of 50. You put her on supplemental oxygen and her pulse ox improves. What do you think is the cause of her hypoxia? The correct answer here is abnormal VQ mismatch. We know that it's not shunt because we put her on supplemental oxygen and her pulse ox improved. We know that it's not decreased atmospheric oxygen because the question never mentioned us being at Everest Base Camp. You could also make an argument that the patient's hypoxemia was due to hypoventilation, although if we did the alveolar gas equation, the hypoventilation with a PCO2 of 75 would not account for her hypoxemia. That finishes up asthma and COPD in our introductory to applied pulmonary physiology.